Hello everyone, welcome back. Today we'll be discussing about gastrointestinal disorders. Gastrointestinal tract is about 5 to 6 meter long and consists of upper, that is oral cavity, esophagus and stomach, and lower, that is small and large intestine, gastrointestinal tract. So one by one we will be discussing about the GI disorders. So first topic is TEF. What is TEF? That is Tracheoesophageal Fistula and Esophageal Atresia. So let's see. Esophagus does not develop properly. What does it means by esophageal atresia and tracheoesophageal fistula? In both cases, esophagus does not develop properly. So esophageal atresia, congenital failure of the esophagus to develop continuous passage from pharynx to stomach. Tracheoesophageal fistula, TEF, abnormal connection between esophagus and trachea. So we'll be see in picture also as well. See, abnormal connection will be there between esophagus and trachea. Let's see. See picture A, B, C, D, E. Especially if you see the abnormal connection that will be seeing in picture D or picture C, right? So let's see. Now coming to pathophysiology. During 4th week of embryonic development, cells of endoderm form primitive gut. Okay, so from 4th week of embryonic development it is starting. So defective separation of gut and incomplete fusion of tracheal fold or abnormal growth of cells cause this defect. Approximately 50% neonates with TEF also have other anomalies that are represented by acronym, that is factorial. Whatever you say, that is same according to your pronunciation, just you have to remember this mnemonic. So let's see one by one. That is V. V for vertebral column defect, A for anorectal malformation, C for cardiac defect, TE is tracheoesophageal fistula, R is renal anomalies, L is limb anomalies. So revise it again. V is vertebral column defect, A is anorectal malformation, C is cardiac defect, TE is tracheoesophageal fistula, R for renal anomalies, and L for limb anomalies. Clear? Now coming to risk factors. So first will be polyhydramnios, amniotic fluid more than 2000 ml. Clear? Premature infant, that is born before 37 weeks, and low birth weight babies below 2.5 kg, single umbilical artery. Now types. There are 5 types of tracheoesophageal fistula. So type A is 5 to 8%. It is an esophageal atresia without fistula. Discontinuity in esophagus, but there is no fistula's connection between esophagus and trachea. Let's see in picture. See, this is discontinued, right? Esophagus, but there is no connection between esophagus and trachea. This is esophagus, this one, and this one separately it is trachea, right? So there is no connection between esophagus and trachea. So type B, it is rare. Upper part of esophagus connect to the trachea. See in picture as well, upper part of this portion, it is connected to trachea abnormally. Okay. Now type C, it is the most common type, 80 to 95%. Here lower part of the esophagus will be attached to trachea, right? And upper part is blind. Now type D, it is 1%. Lower and upper part of esophagus connected to trachea. See in picture that upper and lower both is connected to trachea. And type E, that is also called H type, no esophageal atresia, but esophagus and trachea are attached in H shape. See here what they are saying, here esophagus is continued, right, but abnormally they are connected with trachea. That's why it is that here in this condition in H type, it is also see the structure is almost like a H, if you see. Okay, so here no esophageal atresia, but there is tracheoesophageal fistula. Now it is clear. Coming to clinical manifestation, see 3 C's, that is called coughing, choking, cyanosis during first feed. Then abdominal distension will be there, frothy saliva in mouth along with excessive salivation or drooling. Then regurgitation and vomiting will be present, increased respiratory distress during and after feeding. So in clear language, what they are saying, 3C, coughing, choking, cyanosis during first feed. Whenever you are trying to feed the baby for the first time, all the 3 symptoms will be present. That baby will cough, baby may have the choking symptoms and cyanosis as well. Then abdominal distension will be present, then frothy saliva in mouth along excessive salivation or drooling. In whatever we do now, when you are listening to my session or I am already talking, right, so automatically we are swallowing our saliva, but that baby cannot. That's why that frothy saliva in mouth will be present. Okay, and vomiting, regurgitation. What is regurgitation? That is coming out of whatever food we are giving, that is coming backward, right? That is regurgitation, and vomiting as well. Then increased respiratory distress during and after feeding. Clear? Because trachea is compromised, right? That's why respiratory distress will be present during and after feeding. Now coming to diagnosis part, X-ray show air bubbles in the stomach. Large size orogastric tube stops after distance of 7 to 10 centimeter insertion or unable to reach stomach. Clear? Management part, as soon as TEF diagnose, stop attempt to feed. Obviously, right? Because whenever we are diagnosing the TEF, because we should not give or we should not attempt any feed, because see, there is abnormal connection between GI and trachea. Whatever food particles or milk or we are giving, not food particles, that will be only breast milk, right? Whatever we are giving, that is already in liquid form. So if it is going to lungs, so that will be like a very serious condition for the baby. That choking will be there, baby can't breathe, so we should not give that. Then monitor for dehydration and administer IV fluid as per need. Clear? Because we have to assess for dehydration symptoms, because baby cannot take feed by orogastric line, right? So we have to give it parenteral line, like see, administer IV fluid as per need. Then turn the patient frequently to prevent atelectasis and pneumonia. Clear? Then give supine semi-upright position, that is 30-degree elevation, to prevent any aspiration. Then suction upper esophageal pouch and pharynx at the interval of 5 minutes, because I have already told that you and me both can swallow our saliva simultaneously without even knowing that we are swallowing, right? But that baby cannot, because there is a blind, like blind pouch if it is there in upper part of GI, so that baby cannot swallow, right? So that's why we have to keep suctioning at interval of 5 minutes, then not given anything by mouth, that will be NPO will be maintained, and only IV fluid to be administered. Clear? Now surgical management. See, there are 2 types of surgery are most commonly used. One is if distance between lower and upper part of esophagus less than 2.5 cm, do ligation of fistula and anastomosis of both ends of esophagus. So see, in picture I can show you clearly. See, they are saying if the distance, this distance, right, this distance is less than 2.5 centimeter, then we can do a ligation, right? In one step it can be done. So see, it is written, if distance lower and upper part of esophagus less than 2.5 centimeter, do ligation of fistula and anastomosis of both ends of esophagus. Clear? Now if distance is more than 2.5 centimeter, in this condition infant is poor performed. So staging surgery into 2 stages. Clear? So we have to do in that case in 2 stages surgery. First stage, esophageal fistula is ligated and gastrostomy is performed to provide feeding. And gastrostomy feeding, see surgical creation of gastric fistula through abdominal wall, used mainly for introducing food into stomach, because if you are not introducing any food to stomach, that stomach will be collapsed, like it will be decompressed, right? So that's why we are doing gastrostomy here. See in indication part, see it is written to decompress the stomach and prevent aspiration. Clear to all of you? And second is esophageal atresia requiring a temporary gastrostomy feeding. Okay, infants requiring prolonged artificial feeding. Then observation during gastrostomy feeding is check residual amount before feeding. If residual amount is more than 100 ml, then not give next feeding. In case of adult, it is around 250 ml, right? We know. But in case of newborn, it is 100 ml. If it is more than 100 ml, then we are not giving any feeding. Then because large residual volume indicates delayed gastric emptying, which may cause aspiration. Again, if we are giving food, then it will be causing aspiration. Now keep the tube clamp and funnel should be 20 to 25 centimeter above the level of stomach. When we are giving gastrostomy feeding, that tube will be clamped and the funnel should be 20 to 25 centimeter above the level of stomach. Otherwise that gravitational force will not work, right? That's why we are doing like that. Then we have to check pH of gastric aspirate. It should be 4 or less, because 4 is acidic, right? That's why it is checked, because if it is not, it is more than 4, then it is basically alkaline. That's why we have to check. Then feed should be lukewarm and at the end of feeding instill small amount of water and clamp it, because otherwise that food will be stuck in tube, right? That's why we are flushing with small amount of water. Clear? Now second stage, perform esophageal reconstruction with a segment of colon at the age of 18 months. Clear? In first stage we are only ligating the both part, lower and upper part of the esophagus. In second part we are doing esophageal reconstruction with the segment of colon at the age of 18 months. Clear? After this repair, gastrostomy is closed and starts oral feeding. Now we can do clear oral feeding, right? Now we can start the oral feeding. So hope it is clear to all of you. So let's see it again. Whatever we have studied now, that is pathophysiology of tracheoesophageal fistula and esophageal atresia. Then what all are the risk factors? Then types. There are 5 types: type A, type B, type C, type D and type E. Type E is also called H type and type C is most common type. So it is asked in exam. Clear? Which type is most common? So that will be type C. And in case of type E also they can ask you that which type is called type H. So this two is very important in exam purpose. Okay. Now clinical manifestation we have already studied, that is 3C, coughing, choking, sinuses. So that also thing also you have to remember. Then diagnosis, how we are diagnosis, that is by X-ray. And large size of orogastric tube, if we start to insert, then we can see that after 7 to 10 centimeter it is unable to reach stomach. Clear? Okay. Then management part, feed, we are not giving any food by mouth. Clear? Then we have to monitor for dehydration and IV fluid as per need. Then position, it is very important, 30-degree elevation. Okay. Surgical management also we have seen. So hope it is clear. If it is less than 2.5 centimeter, we are doing one stage. Okay, we are doing in one stage. But if it is more than 2.5 centimeter, then surgery is to be done in 2 stages. That is, first stage will be, first we are doing ligation and gastrostomy for the feeding, and second part we are repairing with the colon, right? And After recovery, we can start oral feeding, and gastrostomy will be also repaired, right? See, yeah, after that this repair gastrostomy is closed and starts oral feeding. So clear to all of you? So thank you so much for hearing me.